Good morning. Thank you for joining us today for the Pediatric Environmental Health Grand Rounds series. The Southwest Center for Pediatric Environmental Health is one of 10 pediatric environmental health specialty units known as PACUs in the United States. The purpose of the PACU program is to serve as a leading national source of medical information and consultative advice on environmental conditions that impact and influence human health throughout reproduction and pediatric development. So to serve as part of our mission, we offer this Grand Round series. And today we're fortunate to have Dr. Rebecca Campos speaking with us on common rashes from environmental exposures. Before we move on, I want to acknowledge our funders, the CDC and the EPA, as well as the Public Health Institute, are all our primary funders for the PACU program. If you would like to earn CME and CNE credits, we ask that you use this QR code. We will also include the link in the chat throughout today's session. But please remember that the activity code for today is 4090. 4090. Our next Grand Rounds will be on Thursday, June 12th at 11 a.m. Mountain Time. We're going to hear about longer-term pediatric respiratory health and development from wildfire exposure. We have many trainings that we provide through the PACU. If you are interested in signing up for any of these trainings, or if you'd like us to have a specific training for your group, please email us and we will put all of that email information in the chat throughout the day or throughout the hour. We are currently doing several trainings on pesticide use as well as childhood cancer as they relate to environmental exposures. So without further ado, I'm pleased to be joined today by Dr. Rebecca Campos. Dr. Campos completed a residency in family medicine and has since practiced a full spectrum family care, including pregnancy, delivery, newborn through adult care. She has served in academic medicine since completing her residency, training resident physicians as they develop the medical and procedural skills to serve as physicians. She completed a fellowship in integrative medicine to expand treatment options such as herbal and botanical medicine, supplements, and nutrition that align with patient goals. She also has completed a physician acupuncture course to provide acupuncture treatments as an adjunct treatment option for a variety of different conditions. We're very fortunate to have her today with us, and she will be speaking on common rashes from environmental exposures. Thank you so much, Dr. Campos.
Good morning. Thank you for having me. I'm going to share my screen. There we go. Does that look okay for everybody?
We cannot see your screen yet. Oh, there it is. It just popped up.
A little delay there. Thank you. Okay. So as Dr. Monks mentioned, with my background in integrative medicine, a common theme is just with all medicine is getting to the root cause. And one of the things that we tend to see is a lot of skin reactions, and a lot of the times we're just putting on our investigator hats. So my goal is so that we can have a better approach or help to streamline some of the more common things on our radar. I'll start with my disclosure statements. I have no financial or conflict of interest things to disclose. My objectives will be focusing a little bit more on certain presentations of clinical rashes that we'll see. This hopefully hoping to distinguish the difference between the allergic contact dermatitis and irritant dermatitis, identify the clinical presentations of these common rashes in pediatrics, as well as the variety of how some of these can vary in their presentation, recognize the role of airborne sources in dermatologic rashes, and this will affect both pediatrics and adults in certain populations as well that we'll see based on occupation and their environment. And then lastly, to just establish a very gentle skin and generalized plan that caregivers can provide as alternatives to home to try to minimize the irritants that they may encounter more often inside the home. That tends to be something that I see more in clinic. All right, when I was first developing my ideas for this presentation, one approach was just looking at the actual, antigen, irritant, and the culprits initially versus the skin conditions themselves. And so then it became this long list, which I continued to have to trim over the last month to 2 months. So today what I'll focus on are the ones that we see most often. Atopic dermatitis is probably a theme that we've all heard of, being that it's one of the most common skin disorders in children, especially in the United States. Contact dermatitis, irritant dermatitis, urticaria. But some other things to just keep in mind that we won't have time to address today is some of the less common presentations like blister or exfoliative reactions that we'll see based on an allergic or irritant encounter, and vesicles of different types. So the first overview on atopic dermatitis is something that we learned to call eczema or eczema dermatitis. One of the things that's important for us to see, especially as we approach summer and this being a national audience, is the different demographics and different skin tones, different sun areas, and the amount of sun that we get. So I wanted to make sure we emphasize different skin tones in the way presentations can vary in some of our conditions. Here's one that's a little bit on the darker side, and what we'll see in this atopic dermatitis, which is often called eczema, is not only do we see the excoriations or the scratches from the clear pruritus that predominates this, but also some lichenification. So you can see here some striations of the chronic presentation, as well as what we'll see is a hyperpigmentation, which I'll reinforce later. For atopic dermatitis, we're seeing that most typically this is a chronic condition. It'll be recurrent, so they'll have the waxing and waning presentation and the relapsing inflammatory presentation that can be acute, as well as the chronic. I think we're all very well aware that there's a genetic and an immune component and in the environment component. So we tend to recognize that there is the intrinsic response and predisposition of a person from the food allergy and otherwise to the extrinsic environment. And I'll try to focus a little bit more on the home environment. As we know, as I mentioned, in the United States is very predominant in pediatrics, but in reality around the world, this is one of the most common conditions. Depending on the literature, we will see 1 in 10 to almost 2 in 10 children will have atopic dermatitis at some form or another. But what's really important is that your history and your patient's complaint before you even have to ask is the bothersome itchiness. So many of us in primary care will call it the itch that rashes, because that will often precede the physical manifestation of what we see. So when we look at the global impact of atopic dermatitis, you will notice that, and again, it's only from 1971 to 2017, but if you see the publication 2022 and was cited in an article from earlier this year, this is one of the more recent maps that I could encounter that gives us an idea of the prevalence and the impact of atopic dermatitis in our populations. I had to go through the page because I was very surprised about Alaska being very rural. One of the things that we'll notice is the more industrialized, more urban type demographics is where we'll see the higher prevalence of it, and Alaska not being one. But it is lumped in as a country, so as if you highlight here on the website itself as a resource, all of this will light up because it's paired in with our mainland here. So here's a little bit of an idea on the spectrum of its presentation. You can see the red, angry, acute presentation, but you can also see some of the dry skin periphery. So you can tell that this is probably more of an acute exacerbation on someone with some chronic skin changes from maybe not a fully treated atopic dermatitis versus this is just a very aggressive presentation. And this may be as a result of the sensitization that someone was previously exposed to in the allergen. And on their re-exposure, they get a very more aggressive presentation, something that we all hear with anaphylaxis and other allergy presentations. Here in the middle, we're appreciating the flexor region. And we can see that not only there is some the redness and erythema from the inflammatory response going on, but you definitely see the excoriations from this young child's scratching, very difficult to control that. And you also can see some of the thickening of the plaque as it grows, but they tend to not be satellite and convalescing, it'll be growing. Here we can see the pallor that happens with the chronic presentation and in this area, which actually just saw last week in an adult, is that hypopigment or dyspigmentation that happens in the chronicity of atopic. And you can see some of the lighter surface accumulation, what we tend to call like lichenification as well. So one thing that's important when we look at presentations from vesicular, papular, scales, and plaques here is also the distribution that we can see between infancy to adulthood. So this is from the American Academy of Pediatrics, and we'll see that in the infant, very young age, where you tend to see a more scaly and crusty presentation. You can appreciate a lot of this extensor areas. And then here, from the adolescent to adult, notice that now we have more of our flexor areas. And in the child to early adolescent, you can see more of a patchy or what we call nummular presentation of the skin lesions. And as adults, we tend to see the hands and the feet. Now, as far as that, so there's some suspicion, the hand's going to have more barrier compromise from our hand washing or more that we do with our hands. But this tends to be our pattern of what we see. And the other thing I'll highlight is notice the eyelids here. So we're going to have a whole little area on that and some of the things that we've been seeing more recent to impact our eyelids and eyelid dermatitis. So from the atopic, just to, again, overview and make sure that we recognize the importance of the implications that this has in our children in school age. There's the emotional impact as they're developing their emotional social skills and how these skin lesions, based on their size, severity, and where they are, can impact, get worsened by sports or make them avoid it because the perspiration and stinging that happens from that already compromised skin is worsened. This can affect their social development because they might be more shy, withdrawn, or even just flat out rejection, the teasing, the bullying. But the other component from the school age children is the difficulty with their sleep because of the ongoing pruritus that tends to be very difficult. Because as we know, once you start the scratching cycle, it is very difficult to control. And so what we'll see is their sleep is compromised, that focus and concentration is negatively impacted at school. But it's important to just keep those things in mind that aside from just the disease, addressing the other things that are going on. Now, based on different literature, you'll see how overall, as the prevalence or the incidence of atopic dermatitis is growing with more cases being either recognized and overall just seen. So up to 2 to 3 times more, typically more in the United States is what we're seeing. The other thing that happens that we will notice is onset and diagnosis will usually happen very early in age. So those who are predisposed to developing atopic dermatitis, again, that genetic familial component, will initially present early, 3 to 6 months of age. But we also can see that by 1 year, about 60% of atopic dermatitis are already presenting and being recognized. And 90% of them have already shown themselves by 5 years of age in children. So here's an important comparison to see some changes of an acute. So we'll see some of the redness, and I'll magnify some of these images in a little bit. But we can see a little bit more redness base here in their lighter skin tones. And as we progress, we'll see some chronic changes. Here's some more acute, kind of looks more urticarial here. But we do see some more confluence of it And as we see chronicity, you can see the hyperpigmentation versus redness and some depigmentation. We see some more hyperpigmentation tendency with darker skin tones here. So here's another image to magnify a little bit more of the red base, the erythema, from how the different presentations can look. A little bit more folliculars, for example, here versus a little bit more patchy and large plaques. Here, as we're uh, progressing into some more darker skin tones, you can see a little bit more, again, diffuse here versus maybe a little more follicular. I know some of these were hard to find some good quality pictures that can show well on screens. And then here's some more towards the end of the spectrum with the hyperpigmentation. You can see where the skin looks a little bit more thickened in this area where my arrow is. The thickening of the skin from the chronic, the scratching here in the back of that person here as well. Now, this was a good example in a pediatric, this was a young child, showing how there's also some hypopigmentation as well here, aside from what we see as dry skin as well. What I'm sure a lot of us have heard is the food impact as a cause of eczema flare-ups. And the most common that we're aware here, food, milk, soy, peanut, and wheat. But what I wanted to introduce today is a little bit better recognition on food preservatives and additives. And as we know, we're recently getting some more like FDA implementation for the red dye being removed from foods and so forth. Here is a link that FAIR, the Food Allergy and Research Education, with some handouts. This link will take you to a list of some of the more common food additives and preservatives that have shown allergies and intolerances. So not everything is a full allergy. There just may be an intolerance, just like we recognize. And an example would be celiac. There is a immunologic response to celiac gluten versus just an intolerance where we won't recognize the anti-CCP and other transglutamate antibodies, for example. One that stood out to me, because I tried to trim this down from being an excessively long list, is this butylated hydroxytoluene. That is a very unique name, but in reality, we'll come across it much more often. So it's an additive that has an antioxidant role, but we'll see this in things like cake mixes, potato chips, mashed potatoes, some peanuts. And what that stood out to me, because if somebody notices a response, we have to take a look and say, well, is it the peanut or is it the antioxidant that was added to it? So just keep that in mind. The surprise for me with this butylated hydroxytoluene was finding it in chewing gum. So something that was not definitely on my radar, but was shown finding a case report of that producing an urticarial reaction in a female. So just make sure that we're able to identify the dermatitis reaction being allergic versus more of an adverse reaction as well. So just keep that hopefully in mind. And of course, at the end, skin testing will be one of our main mechanisms to recognize, identify, and our trigger there. MSG, the monosodium glutamate, something that's been very recognized as a trigger for many presentations. I've had a patient with vertigo knowing that they had to avoid all potato chips and things because that caused severe vertigo, to migraines in another patient that I've had. And then, of course, here, food, skin is another recognized presentation for that. And then looking at atopic dermatitis, consider the allergens and the irritants, the environmental factors. So right now we are located in the desert. This dry area will allow for more compromising of the skin with dry skin. Heat can be more of compromising situation or condition and climate than a cool area. So humidity has a benefit, then the dry, cooler has a little bit benefit as well. Keep those in mind. But also on another end, the combination of allergens and environmental factors, today's going to be really high in the 90s here in El Paso. That high temperatures can also affect different pollen duration and of exposure to in your environment. So keeping that in mind is not only the environmental skin compromise predisposition to the allergen trigger. And then of course, once we start our immunologic or skin response for that dry itch cycle, we're compromised. Superimposed bacterial infections opportunistically will take advantage of that. So all of these can be modalities of focusing your treatment as well, making sure environmental factors, they're bathing, They're moisturizing, minimizing irritants perfumed in their lotions and so forth. And then also protecting their skin and minimizing that itch cycle. So just as we hear the itch that rashes, I also like this saying in this article. It says it is not the eruption that's itchy, but the itchiness that's eruptive, because we will also see that more than others. But just keeping that in mind from the type of even bacteria that they can be more colonized and compromised too with Staph aureus versus Staph epidermidis, which tends to be a less severe skin issue. Picking out my pace a little bit more, here's another example of the dry, the lichenified linear changes that we can see in the area, but obviously the compromised skin that we see here. And more recently, an article within the last few years came up showing that atopic eczema is an environmental disease. So one negative factor for a person to develop it is you're more at risk in an industrialized living, the urban, being around the vehicles, the automobile, the air, exhaust, also very hygiene and sterile, over-cleaned environments as well, versus the farm effect that we see, which will also carry into the biodiversity theory. So in the farm effect, those who live in farms around the animals or the barn, the soil, the good bacteria as well, we do see a much less incident of atopic dermatitis in those who live in more ranch farm to even one study citing like the Amish having much less to very little eczema types issues. So just keep these in mind, and how breast milk fed, we know with probiotics is helpful. They're very aggressive, strong detergents. Hard water is another risk factor as well. The use of hard water compromises the skin more. Soaps tend to be very alkaline and part of their function for cleaning, but this can also negatively impact the skin barrier. So just keep that in mind for your patient's social history. And when it comes to someone who already has compromised dry skin, you can also consider the lotion you would recommend. You know, maybe usually they do tolerate a lightly perfumed lotion, but while they're in an exacerbation, it's good to avoid it. Those who are just very sensitive, avoid it altogether. And it's hard for a patient to go who is non-medically background, go to the store and identify fragrance-free versus unscented. It tends to sound both the same, and both seem to be great. And that's actually not the case. So you see here, this is a handout from the EPA. And this is a handout that I like to keep printed in clinic to hand out to parents because it's so much information. Avoid this, do this, and avoid that. So this is a really helpful one so that we know fragrance-free means that they are not masking the scent. And unscented doesn't necessarily mean that they're not there from those alcohols that provide the smells that we like so much. Instead, they'll add more and more to neutralize it so that you just don't smell it. Doesn't mean that it's not there. So fragrance-free when it comes to diaper wipes and lotions and whatnot, that's the way to go. Just to wrap up the biodiversity theory as well, though, the exposome is everything that we come in contact with. So the more that we come in contact with in the exterior environment is better for our microbial diversity, which I'm sure we've all heard at some point or another with their microbiomes. The more diversity, the more protection and competition for the opportunistic infections that we would want to avoid. And that's not just in the GI where we tend to hear a lot of that, but also in our skin flora. All right, so transitioning to contact dermatitis, I do want to take a look at two types. And if I had a time for the nice or to expand on a good Venn diagram, we would see while there is both an allergic and an irritant dermatitis, both in contact, there's also an overlap in both. And we'll go over a little bit more on that. So in the allergic dermatitis, we do see an immune inflammatory response that are tied in together in our manifestation. You'll have a person who is predisposed, but you also have the sensitization factor, whether that's an organic or inorganic material like a metal or a chemical. Something was triggering some sort of immune recognition. And in their subsequent exposure, then you have the more rapid onset and development of symptoms. Versus an irritant dermatitis, it could happen to more anybody, not just your predisposed. You typically will not have an immune response, but you do have your epidermal or surface modification, whether it's a physical traumatic barrier compromise or a chemical irritant that we have, like, as many of us are healthcare workers, like hand sanitizers. I know during the pandemic, I developed my own skin sensitivity to all the hand sanitizers that we had to use on, every 10-minute basis, basically. And so the type of contact dermatitis will be an important factor. But note that in an irritant dermatitis, you can have an acute presentation where you will have probably more of a localized manifestation, that's the direct contact compromised area, to a chronic with recurrent, where it can then start to spread more, but it's not necessarily a significant hyperbole of a response because of that sensitization factor that's not there here in this case. Focusing on our first type, the allergic contact dermatitis, we know that it's a hypersensitivity response, or type 4. It's T-cell mediated, explaining the inflammatory. So in our stage process, you have your initial exposure, may not have the dramatic response as we see in allergies, but we're sensitized now. And that elicitation with the re-exposure is much more aggressive in that primed response. So what will help here is looking at the location of the exposures, air exposed, sun exposed, heat exposed areas, even clothing exposed if it's certain things in the clothing material or dyes. Acute versus chronic. So in the acute, it's more red, angry, maybe even vesicular, can be weepy, versus our chronic, where now we have more thickening, lichenification, scales, and so forth. So one common contact dermatitis that I think we're all very familiar with, so quickly touch on it, is like our poison ivy or other botany-based ones or plant ones. You can have, as you see in this first picture, our linear exposure based on the direct contact, or the blister, this vesicular and bolus type presentation from it. But what was really interesting is, our lives are changing. We're not outdoors as much. So fortunately, earlier this year, as we saw like a map referencing it, this new article came out. And it looks in this age window, a time interval from the 2017 to 2022. And in this retrospective study of a decent amount of patients, we did see some patterns on skin testing. And what of all of this very intense chart that it showed, the ones that stood out to me the most is in this young group. So the highest and most common responsive skin test, it was positive, was in these two age groups from 6 to 11, 12 to 18. So 6 to 18 from young children to adolescent and young adult, and in females. And the most common allergen was propolis. We'll go over what that is. On the other hand, in that younger age group and in the male, we also saw the most common allergen being carmine. And many of you may have heard of that. So what are these two? Again, it's an extensive list of many other things that we'll lightly touch on, but a little bit more on these two. And the propolis, we see this is more of a derivation. So what we've derived from beeswax and other products and oils from bees, which is something that we see a lot in our lip balms, in our creams and moisturizers. There's brands coming up with just bees type, very well natural, less chemical, but still it has been seen for it. And so we actually use propolis even in our healthcare. There's oral treatments for diabetes and oral lesions. Has been helpful to treat the ulcers or aphthous ulcers that we'll see as a result of chemotherapy. But in the general public, it's very prevalent to be seen in cosmetics and moisturizers. This can actually also be related to a lot with like lanolin. Carmine, though, is actually a red dye, and it comes from two key sources. The one is insect bits. So it's basically an insect that inhabits the prickly pear, but in its breakdown can provide a red dye, and can be seen as, instead of a chemical red dye, this is now more of a natural red dye, but can also be used in food. So if you see food in food dye, beverages, and medication. So first we'll take a look at some lip lesions. So if I were to see somebody like this, I would ask, what have they been putting on their lips? This one is a direct response to lip balm and lanolin. But you may also see it in other, the honey-based ones. But we also see it in their younger children with lipping as more as an irritant dermatitis. So again, location, history, and what your history reveals in your exposures is going to be important. And back to the carmine, not too long ago, you may have heard about this in the news being a major thing for Starbucks. So this was used, and I think Starbucks, with the intention of not having so much chemical, was using this, but now it had to be a warning for vegetarian um, population and their customers, because carmine has been used in many foods, and as you see here, cosmetics as well. But we really made the news when it was found to be part of the strawberry dye in our Starbucks Frappuccinos and other drinks. So it was a big thing about eating bugs and drinking them now too. Another contact allergen that's been well established for many years is nickel. And so this one is very classic. Earrings will be a good location if you see it in the ears, not just the gold and the silver, but nickel, as well as belt buckle and the buckle of jeans and pants. So you'll see this a lot in pediatrics, very common there. And on this list of common contacts, if you notice, bacitracin and neomycin are in there. So these have been well recognized as just even the general public for contact allergens. But it's important to note that in children, how many times is there a scraped knee or some little cut, and right away we put a triple antibiotic because it's easy to capture. Most will respond really well, but it's important to recognize these top two as potential triggers for dermatitis. So neomycin and bacitracin, which I still continue to use as well. But if I'm not concerned about allergen and I'm looking at more of the emollient, then look for something that's more of a um, maybe single antibiotic or a petroleum-based, even just simple Vaseline to help the healing process if we're not concerned of infection. And you'll see here, your big clue is a post-surgical inflammatory response, like in our first picture here, where you're not as concerned as much about infection, but more the prophylactic antibiotic that was placed after the surgical or procedure here. But both of these earned the title of Allergen of the Year by the American Contact Dermatitis Society in 2003 for bacitracin and 2010 for neomycin. So I bring this up because it's very common to see in residents for years that very quick to just put some neosporin. And in reality, if it's not really indicated, I try to catch that and say, well, if you're not, don't need to worry about it. Maybe just use a single bacitracin packets that we'll use in clinic that aren't always triple antibiotic. But neomycin did relate to more percentage of contact sensitization when patch testing was done, up to 13%. And this was back in the 1990s, like before 1998. But it was based on the data looking at those sensitization results, and that's where it earned allergen. Bacitracin, on the other hand, was at a lower amount, around 2000 when that data was looked at. It was about 9.2% of our positive findings there. So pretty common there. Heavy metals can't be ignored. Again, nickel, reiterating it, but the hypersensitivity reactions that we do from that can vary from very mild eczema to very angry lesions like the bullae, the blisters, and inflammatory weepy ones. So when it comes to contact dermatitis, not only is there the physical contact, but one thing I wanted to spend some time on is the airborne. So what we also call ABCD now. So airborne contact dermatitis. So is it an allergen or is it an irritant? It all depends on your history and what the trigger was, which is very difficult. So while this might not be, these were some case articles that I came across because I've had a few instances in clinic over the past few years that I suspected it was something more volatile and flowing in the air, was more of aromatherapies and scented. So whether it's, especially during the holidays, there's very much of the cinnamon and plug-in scented devices now that we need to keep in mind. So those heated fragrances can be more concentrated in our candles, but the incense and the diffusers, especially diffusers like in a vehicle, so you'll actually see some of these in share drivers. So those ride share drivers are constantly in there because you want those good 5-star ratings in your ride. So the positive experience in that is making it smell well, smell really nice during your drive. But what was noted is this facial and eyelid dermatitis developing. So the face obviously was more exposed. Remember, Heated and more volatile substances will be more concentrated in the dry areas, so keep that in mind as well. But one thing about the eyelids to emphasize is that while now they've been um, recognized here for a few things, one is fragrance and scents, and the other one is even cosmetics and artificial nails, the acrylates in there. So here, just keep in mind, eyelids are very thin. They're very sensitive. And since, as we note here, when you're blinking, your eyes are closed, we have a nice compression of that eyelid. So you have thin, sensitive skin that's already more vulnerable and then has a compression of whatever deposits may have accumulated on the eyelid. So think of what modes of exposure, whether it's vapors, gases, smokes, or droplets. Think about phototoxic exposures and then the presentation. So these are all different article types of themes that I came across, all related to airborne ones. So as you're looking to a source, think of what allergen can get exposed there. Um, Nail polish, nail gels, acrylates from the artificial nails, fragrances, sunscreens would be coming up as one potentially as well. So if they're not sure, zinc oxide versus our other titanium oxides, you have to pay attention to what they've been exposed to. Preservatives. So what preservatives would also be in not just the foods, but also in the skin products that they use as well. Keeping up with our pace is the irritant dermatitis. So here is something that we can relate to for many of us in any area of healthcare, constantly cleaning our hands, thanks to our hospital and healthcare systems that we need to be grading. There's so many hand washing campaigns. So the lauryl sulfates or the triclosans can be our irritants. You'll notice that this is actually after a week, just a day of being in the hospital myself. The irritant dermatitis from the hand sanitizers. Cosmetics, so retinols, retinoids for anti-aging therapies from the face, getting used to the down to the nakes or the decolletage. I'm not pronouncing that right. That exposure can also be an irritant and compromising the skin. So that's what this one here is about. And as I mentioned earlier, the acrylates that we notice in nails, but also in adhesives and paint. So if somebody's even painting rooms, maybe that's an area. But we do know that this has been more prevalent. I don't have new data showing a good perspective. That would be a great study idea for anybody here. When I go get a manicure, I may actually see young little girls and a lot of teenagers getting their nails. So it might be something to keep in mind on our radar when we do see this eye issue, that make sure we're asking about any recent nails or getting their nails done, things like that. Here's a youth with that same presentation, and this one was also from cosmetics and eyes. So just remember the thin and compromised eyes. So this is a single presentation. Here you can see the very fine pustules. So this person has a history of allergic contact and dermatitis, and after getting their nails done, had this extreme peri-eye, or around the eye response, and then spreading through the rest of their face as well as their hands. So after removing their nails and starting their topical steroid, they did respond, and resolution happened. One of the most common, if not still the most common irritant dermatitis in pediatrics is in our infant, and as a result of the diaper dermatitis, because of the wet to dry cycle that they're constantly having with all those diapers they have to go through. But one factor too is these super absorbent type of diapers, which are a relief for us parents, but also can be something that they might stay in the diaper longer. And that irritants can lead to more of that diaper rash. So not necessarily am I talking about the Candida rash, I'm talking about the diaper rash. So something to pay attention to is the pattern around the elastic of the diaper to the upper area here to just the whole diaper region that's covered. And then friction irritation. So in our youth that are in sports and athletics, think about areas where they perspire and there's more friction. So chafing of the axilla, the type of the equipment that they use, The clothing and the chemicals that are used for that, some more airy clothes would be better, but some clothes might be more of an irritant to some more than others. And then the dye that are used in their clothes. So important that they make sure to wash their clothes before they use them. So for the irritant dermatitis, typically this is not considered an immune response. It is more of a direct irritation, traumatic problem causing skin findings. So it's a barrier disruption. However, that Venn diagram I mentioned is that because of that compromised skin, now an antigen is exposed, whether it's chemical or biologic or not. That potential is an exposure and a potential for sensitization to lead to now repeat exposure of that same irritant might actually develop more of an atopic or an allergic dermatitis on those subsequent exposures. So what helps is in an irritant dermatitis, usually it's their first exposure. It usually can determine its onset from within a few hours, and its resolution, more importantly, will be quicker within a few days versus weeks in an allergic dermatitis because you have a more diffuse systemic response. So remember, while prevention is key and avoidance of it, some of it is not possible, especially in athletes. So barrier creams are important. It's important to use them properly with earlier application before exposure to the hand cleaning sodium lauryl sulfate or before the friction, before what may be. On the other hand, while emollients are a potential solution, they can also be a potential risk factor. So if it's prolonged daily chronic use, it's actually been shown to be less effective and maybe more of a risk for dermatitis. So that doesn't make it easier for us. And then just to lightly touch up and wrap up for time's sake is urticaria, because this is something that will present frequently. And I just want to quickly overview on this so that I'm still considerate of your time here. When it comes to contact urticaria, you'll hear a lot of things that overlap, like with our allergic dermatitis, where you can have acute versus chronic nature from new exposure early on to recurrent flare-ups of urticaria, which we know as hives or wheals. But in children, please be cautious of angioedema, some facial or eye swelling that comes with those acute urticarial symptoms. And again, immunologic or non-immunologic, just to reinforce that one more time. But the stimuli can vary. Stimuli can be a contact, it can be vasculitis, but it can also be chemical. So I thought this was a very nice chart to help us give a little bit of leverage to some differential, help us focus that differential in history taking based on the time of how long your patient's symptoms can be. But those that land I've had for weeks to days to weeks, you do have to be careful of a more pathologic cause and get like a blood counts to look for ugly things like cancers and so forth that we would have to keep in mind. For the most part, it does tend to be benign. The description can be difficult. You can have these large wheals, like this first picture. These are, again, hives or wheals, but you do see a little bit more red, angry, well-defined borders. And most importantly, symptomatically, it's going to be very pruritic. And you may have a regional versus on our second picture here, you have some new, early, more angry or brighter red to more pale, okay? And unfortunately, this is a limitation, there aren't very images that I could find for skin of color to show how urticarial changes can show, because you have to recognize that you may not be looking for redness. You're looking for the texture where your hands are also part of your examination technique. And I do have a couple pictures that show a little bit of changes with skin, but there aren't as many as I would hope to show for today. But for urticaria, think of your categories. Allergy, is it something that somebody ingested? That's why we're having a more systemic, diffuse hive presentation. Is it physical contact, which might be a little more local? Physical irritant, heat. So trauma, you have skin, sun, summer. You have 2-a-days coming up for in a few months as our football players and whatnot are practicing. Cold in the cold summers, I've seen diffuse urticaria to the face as people go out, but the rest of their body was protected from the cold. You can have response dysfunction is what I kind of relabeled it, because you can have an abnormal or triggered reaction from medication, MCA like your mastocytosis or mast cell activation syndrome. Those are different types of triggers, can be from NSAIDs to heat to things that they eat. So very broad triggers, but mast and histamine cell response going on here. And then, of course, malignancy, like I mentioned earlier, needs to be on your radar, especially if it's chronic or recurrent with smaller interval of time. And then think about that workup, autoimmune. Is there something that changed in your patient? Other symptoms that are accompanying it, weight gain, weight loss, what thyroid autoimmune we need to think about. So if you look at these categories, your source of trigger from skin, ask about pruritus, the burning and the tingling, and that's different from dermatitis to urticaria. You'll typically feel a little bit more of a stinging, burning sensation. In the ingested one, you might notice the burning, esophageal, oral, angioedema. Inhaled, if it's an inhaled one, you may notice more of the coughing spells and wheezing, tachypnea, the rapid breathing from that, aside from the skin changes. So urticarial, this first one is a nice example of the dermatographia. Here we had a little bit more of a darker skin tone, showing the raised but small various sizes of hives. And then here's an example of the angioedema here, where you will see the swelling to the mouth, lips, but ideally not the airway, but must be careful with that. And then as far as a general approach for your patients, think about how you want to advise them and how they're to keep clean and hygiene. Avoid the overzealous cleaning, but if you're around a lot of perfumes, things that are oil, aerosols, cleaning that well. Temperature, lukewarm versus very hot. Lukewarm to cool may be better. Gentle dry. So after a bath, it's going to be pat dry, not rub dry. Avoid the friction. And ideally, you'll see data within 3 minutes or within 5 minutes. Moisturize after a bath or a shower. And emollient versus cream is sometimes the discussion. What's better, the emollient, so that you have a good barrier with the petroleum, or the cream? Well, part of it is going to be a problem in terms of what can your patient tolerate. Because if it's emollient, and based on their job or the environment, that can be very uncomfortable to have that greasiness and damaged clothes. So maybe timing of the day is better, emollient at night, cream during the day. What matters is, what can your patient take? The most successful one is the one that your patient can do regularly. Anti-inflammatory, as we looked at the different barriers and different factors in our skin lesions, topical versus more systemic from the recurrent and difficult to control, like needing more of a calcineurin inhibitor. But both of these anti-inflammatory focus on the root of what's going on in our inflammatory pathway. And then symptomatic, help your patient sleep. An antipyretic like hydroxyzine, antihistamine, or maybe not Benadryl, maybe more of a second generation, like a cetirizine or loratadine in your children. But know that things like cetirizine can be more sedating for some children than others, even for some adults, I've noticed. Think of their comorbidities. Do they have a superimposed bacterial infection? Is it an area where they get frequently exposed to bacteria and so forth? So they may need an antibiotic treatment, oral versus topical. Keep that in mind as well. And I think from that, I will wrap it up with that and see if there are any questions. And thank you for your time.
Thank you so much. That was a wonderful presentation. So much information in there.
Yes.
Let's see if there. Let's see. I'm looking to see if there's any questions. Please feel free to
Thank you.
add questions into the chat.
While we're waiting for chat questions to come in, I did have one related to some of the ocular dermatitis that was attributed to the nails. Artificial eyelashes are also applied with similar adhesives. Is there any evidence that these were specifically nail related and not attributed to other adhesives?
So there's two things to that. I started to look into that. I didn't see a lot of articles on it. A lot of it will be more like case reports. And I have seen a lot of eyelash issues actually. And that's when I held back just because of time and wanting to focus on pediatrics. I haven't seen it because most of that is going to be older, maybe, 18 and over kind of thing for the false eyelashes. For the younger, patients, there'll be more the daily applying adhesive and they remove every day versus the ones that are longer lasting eyelashes that we'll see typically more in adults. I have seen that. And I've also seen the permanent eyeliner dermatitises as well. So I actually started to introduce that. I'm glad you brought it up because I removed it because I was trying to focus on pediatrics. There isn't a lot. I think it's just nails and eyelashes have been a very much more growing pattern and over the last few years that I suspect that will be something that we will be seeing a lot more of. And I agree that definitely needs to be on the radar. And they need to go get them removed, especially not try to traumatically remove them from the eyelashes if they were the individually glued long-term ones. They need to go and have them carefully removed with the proper material. That's a great point.
Well, thank you. I will definitely be careful before I get my next set of either eyelashes or nails. Other questions in the chat? There was a comment. Thank you. This information was great.
Thank you.
And I put the QR code link back in the chat one more time for those looking for it.
Shall I stop sharing if you need to share that?
Here's a question that came in. Are retinoid creams hazardous for the skin?
I wouldn't call it hazardous. I do think that there is definitely an aging cosmetic benefit for wrinkles, and we noticed pore diminishing of size with that. The important thing with these is to make sure you've got the right precautions for your patient. They do cause skin sensitivity across the board, so proper SPF sunblock protection is important. It's important that they know to put those in the evenings and at night instead of in the morning when you're going to encounter the sun more. And they do need to know that as a patient gets started on the retinol creams for that, you start at the low concentration and very slowly increase the concentration to what's tolerated for the patient, which may also mean in the summer, like here where we are, where it's Sun City, maybe decreasing the intensity or potency of that retinol to minimize that skin reaction. And for that, typically, actually, what I've seen with those, again, in the older, in adults, is for the patients that do the retinols for the anti-aging benefit, you'll notice a lot of perinasal dryness and peeling happening there. So that's just more so just to be of caution for that. Again, not a whole lot more hazardous, I can say, than otherwise, but I would be careful. Avoid it in pregnancy, things like that. Thank you for that question.
There was just a quick question that came in about access to the slides, and I'm going to let everybody know that thank you for allowing, but we will plan to make this presentation available through a YouTube link within the next couple of days.
Not to throw a new topic in there, but something that we have briefly mentioned as far as with measles as well, just to be aware of that coming up, and skin lesions for it. But aside from that, that's more viral. And actually, one thing to point out is infections, viral infections, one of the most common causes for urticarial lesions too, I believe. I'm not sure if that data has stayed the same from when I've last looked at that years ago, but that's something at least to keep in mind when it comes to just general viral infections in general.
For those of you that are in Oklahoma, I did just share this opportunity. Um, Several of us that are part of the PASU will be in Oklahoma on June 24th and 25th, and we will be doing a children's environmental health symposium there. And we would like to invite you to join us. It is free of charge. There's a QR code here at the bottom, just for registration because we are limited on the number of attendees due to conference space. So if you're interested in talks more, more aligned with environmental exposures and you're in Oklahoma City, we would ask that you join us there. Are there any more questions in the chat for Dr. Campos? All right. Well, I don't see anything else coming in. Dr. Campos, if we get more questions, we'll go ahead and send those over to you. Oh, hold on. There's another one. Dr. Crawford, can you read that one out?
Yes. The question is, do you have a barrier cream recommendation other than Vaseline?
So depending on the patient as well, some of the ones that I like, I can say brand names over the counter, but Aquaphor, Cetaphil has been great. CeraVe is another good one, but I haven't seen as much of the petroleum easily found. I can also say even just a good old jar of petroleum can be helpful if needed. But I've liked the Aquaphor because it's had a nice tube with an like a spongy applicator that you could put. That way I could use the dorsal part of my hands when I went on the hospital and not get my palms dirty when I needed to type or do other things. So that tends to be one that I like for my hands. But those would be great. Aquaphor, Cetaphil, CeraVe, those have been helpful over the counter that you can also find in bulk as well.
We actually ended up with two more questions that just came in. So from the list of eyelid allergens you mentioned, which are the most common ones?
So the data was changing. So there are studies that I actually did find that had more larger numbers, tended to be just more like topical things than these were from more than 10 years ago. I feel that now with what I see in clinic and even in the community, you'll notice sometimes I've noticed the red eyes now at the store. I think that data probably needs to show a more updated, and I think the pattern is probably different. I did have an article. I listed the article in there that has a nice chart of most of the common eyelid antigens. And a lot of them were cosmetic in nature. With very long names, I wouldn't be able to reiterate very easily right now. But that article that I'll share in the access for the slides did have a list, and there are some studies that show like 200 retrospective studies. I saw one with like 203 patients out of Brazil. So those were all adults though, but a lot of it was cosmetic in nature. I do see the SPF question as well. So for many years, the American Academy of Dermatology showed a minimum of an SPF of 30 was recommended. I think now we're at about at least 50, just based on the needs of not just where we are here in the Southwest area, but not everywhere. So to me, an SPF minimum is 50 is a great goal to aim for, but you can find them higher now too.
And from what I've looked into with that, the frequent application is probably as important as the physical number, that there's a lot more mechanical degradation on the SPF than just the physical amount. So.
Correct. Especially in the summer when you're swimming or sweating. You're right. And make sure that you apply it with enough time before that exposure. 15, 20 minutes minimum. Aim for at least 30.
All right. Well, we're right at the top of the hour, and a fantastic discussion and wonderful questions. Thank you all for joining. If there are more, please do email them in, and we will be sure to pass those along.
Thank you.
Thank you, Dr. Campos. Have a great day.